Happy Fall Prevention Awareness Week, everyone. My name is Sydney Shutrow, and I am a member of the Tennessee Fall Prevention Coalition. On behalf of all the coalition members across the state, welcome to the first session of the Tennessee Fall Prevention Coalition's Fall Prevention Awareness Week virtual series. Governor Lee made a formal proclamation recognizing September 19th to the 23rd of this year as Fall Prevention Awareness Week in Tennessee, and this week is celebrated across the country through the work of the National Council on Aging. The series would not be made possible without our amazing coalition members, many of whom are joining us today, who've developed the data collection surveys that you all filled out. Thank you for that. Volunteered to speak during the series and strive every day to educate, promote, and provide programs and services across Tennessee to help reduce the occurrence of falls in older adults. Thank you truly to everyone. For the audience, this session is being recorded. And you'll all be placed on mute here shortly to reduce background noise out of respect for our presenters. If you have your camera on, now is the time to consider turning it off if you don't want to be seen on the recording. If you have any questions or comments to share, we encourage you to do so using the chat box feature, and we'll address questions throughout the presentation as well as at the end. We have a wonderful presentation for you today that will kick off the series with an introduction to fall prevention. Without further ado, I want to turn it over to Dr. Karon Uzzell-Baggett and Debbie Tuggle so they can tell you about themselves and lead us in this discussion. Thank you, Karon and Debbie, for being with us today. We appreciate it.
Thank you very much, Sydney. Good morning, everyone. I'm Dr. Karon Uzzell-Baggett, and I have the pleasure of being joined today by Mrs. Debbie Tuggle, who you'll hear from in just a few minutes. We're here to kick off Fall Prevention Week and talk to you about the impact and cost of falls. Is that me? Okay, I hope not. Okay. Please note there is a disclaimer at the bottom of the first slide. While we are medical professionals, we are not your particular medical professional. So please be aware that this presentation is for education and awareness only. All viewers are encouraged to seek evaluation and assessment from their personal medical provider before engaging in any exercise programs, altering medications, or so on. This is what we'll be talking about. First, we'll introduce ourselves. Then we'll talk about some fall myths. Then counter that with fall facts. Talk about slips, trips, and other types of falls. The cost of falls. And then we'll have a fictionalized case study, Mrs. Case's story. Then we'll have some empowerment and end with questions. Once again, thank you so much for your attendance on this first day of Tennessee's observance. I was like, is someone else controlling the slides?
What just happened? Yeah, someone took it from you somehow.
Yeah, okay.
I'm not sure how that happened.
Okay, let me try to get it back. Okay, you see my slides?
Yes.
Okay, well, hopefully it'll stay on there. Okay. All right, so first off, I'm Dr. Karon Uzzell-Baggett. I'm a certified and licensed occupational therapist here in the Nashville, Tennessee area. I have my own private mobile outpatient occupational therapy service, and I specialize in treating older adults, and I like to volunteer in various aspects of the community with various organizations. Occupational therapy is really a crucial component of fall prevention. Occupational therapists help you do those things, those basic activities of daily living. We also help you do things like getting out into community and taking care of yourself and doing those things you love there, in addition to making sure your home is safe and just a plethora of other things. Now it's my pleasure to turn it over to Ms. Deborah Tuggle.
Good morning, everyone, and thank you so much for joining us on this very important topic. My name's Deborah Tuggle. I have been a registered nurse for 28 years now. My entire career has been spent at the University of Tennessee Medical Center in Knoxville, Tennessee. We are a level 1 American College of Surgeons accredited trauma center. We have an annual volume of about 90,000 emergency room visits and about 7,000 trauma admits. I spent 13 years of my career as a bedside nurse in the emergency department, taking care of everything from slips, trips, and falls to helping deliver babies. And the past 12 years, I've spent as our injury prevention coordinator. So it has been my pleasure to hopefully prevent injuries from happening. I am passionate about geriatric trauma, pediatric trauma, and injury prevention. I do live in Knoxville with my husband, and I have 2 daughters currently in college. So thank you for tuning in today, and we really hope that you enjoy our presentation.
And you'll have the chance to hear from Deborah later on this week also. She's doing a second presentation and making a television appearance. So she is certainly spreading the word about fall prevention this week. Next, let's talk about some myths regarding falls. These were compiled by the National Council on Aging. The first myth is that falls happen to other people, but not to me. The next one, falling is something normal that happens as you get older. The next one, if I limit my activity, I won't fall. And this one, as long as I stay home, I can avoid falling. Muscle strength and flexibility, they can't be regained after a certain age. So hopefully some of you are recognizing some of these things that you might have heard that are really myths. Taking medication doesn't increase my risk of falling. And this gem, I don't need to get my vision checked every year. And using a walker or a cane, it'll make me more dependent, not independent. And this one, I don't need to talk to family members or my health provider if I'm concerned about my risk of falling. I don't want to alarm them, and I want to keep my independence. And then finally, this myth. I don't need to talk to my parent, spouse, or other older adult if I'm concerned about their risk of falling. It'll hurt their feelings. And frankly, it's none of my business. So these are some myths that we hope to dispel in the next hour as we go through our presentation. Sydney, can you please put up the first poll question?
Absolutely. The poll should be live right now, showing up on your screen or in the chat box option. So if you're doing a watch party, you can kind of poll your group and do your answer and then select. So the poll question, Karon, do you want me to say it or do you want to say it? Sorry.
Oh, you can say it. Go ahead.
Yeah, the poll question is, what is the predicted number of fall-related deaths every year by the year 2030? 3, 5, 7, or 9? We have about 16 responses so far, so we'll give everybody another 5-10 seconds. Hopefully we can get, there you go, we're up to 22 responses, 26. My response is not as popular as other people's responses. Alrighty, we have about.
Response box.
It'll show here once I close the poll, so we'll be able to share the results. Okay, I'm gonna go ahead and
How do I
close
respond?
it. Oh, it should be either in your chat box option on the right, or it should have popped up in the middle of your screen. If not, I'm not sure. You can also type it in the chat box what your answer would be. Alrighty, so we had 30 responses and we're having a few come into the chat box, but 10% of the audience said 3, 20% 5, 47% 7, and 23% 9.
Okay, well, thank you very much. I appreciate you doing the poll. Well, the question will be answered in our next slide. Right now, we want to talk about facts. We've just finished talking about myths, so now it's time to start dispelling some of those myths and talk about the facts. When you talk about falls, as you can see, the answer to the poll question is, if fall rates continue to rise, we anticipate 7. So for the roughly 47% that answered 7 fall deaths every hour by 2030, you are correct. And for the other ones, that certainly was a good guess. Now, as I said, falls are one of the top 10 causes of death among older adults. They specifically fall under the categorization, of number 7, which is unintended injury, with falls being the highest number within that particular category. An older adult falls every second. They may fall in the home, they may fall outside of the home. 3 million older adults are treated in emergency departments for fall-related injuries every year. And then 1 out of the 5 falls causes some kind of serious injury, broken bones, either to the upper extremity, trying to brace yourself from a fall, and certainly from the lower extremity. But then you can also sustain serious head injuries, things like concussions or traumatic brain injury. As you can see from the diagram below, the older adult fall burden is certainly increasing. In 2018, it was listed as 36 million falls that older adults sustained. In 2030, it's expected to be 52 million falls sustained by older adults. Now let's look at some Tennessee-related fall data. The Commission on Aging and Disability has done an excellent job of compiling data that encompasses 95 of the counties within Tennessee. When you look at the top 4 counties with fall-related emergency room visits, which you can see on the left side from the period 2016 to 2020, the leading county was, of course, Shelby County at 27,048 deaths. Then it went on to various other counties. Davidson was the second leading county in terms of ER visits at 21,055 deaths, for a total of 292,640 fall-related ER visits. Excuse me, I think I said deaths for Davidson County. I meant fall-related ones. Now, moving on to fall-related deaths during the period 2016 to 2020, Davidson County did have the most deaths due to falls, and that's 429,000. As you can see, the various other top 4 counties, their numbers are displayed there, for a total number of fall-related deaths in the state of Tennessee being 3,364 deaths. Now, moving on to talk about Tennessee fall-related facts. When you look at the demographics regarding fall-related injuries, it's important to kind of break down and determine where we're seeing lots of injuries. In terms of white individuals, this is 5.5% of the Tennessee population who are sustaining falls. Black individuals, 3.6% of the population in Tennessee is sustaining falls. And then for our other racial demographics, 2.4% are sustaining falls. And then when you look at ethnicity, Hispanic, 2.1% are sustaining falls, and then non-Hispanic, 5.2% of the population are sustaining falls. Moving over to deaths, any death is devastating for the family and for the member, of course, the member's friends and relations and so on. In terms of whites, in terms of ethnicity, the numbers, when you look at death compared to the whole population, it's 0.6%, blacks 0.3% at 160 deaths, Other, 0.2% at 19 deaths. And then when you break down ethnicity, it's 0.2%, and then non-Hispanic, 0.6%. But as I said, any death is devastating to the family and friends if fall occurs. Now, you can see that when you're talking about falls, it's important to kind of figure out where individuals are falling. When you're talking about categorizing falls, there's a common language that's used, and that's the International Classification of Diseases, the 10th edition, and that is ICD-10. These are the codes used by medical professionals to categorize the type of falls. It can be anywhere from W00 to W19, and involves everything from slipping, tripping, stumbling, things like falling due to snow, falling while being carried or supported by another person, falling at the same level, falling, jumping, or diving into water. Altogether, there are 20 codes which are commonly used. There are also codes specifically if you have repeated falls, and then codes to identify for your medical professionals if you have a history of falling. When you look at the ICD-10 data for both sexes and also all races for individuals who are older than between the ages of 60 and so on, you can see that the types of falls that you're talking about, most of them are unspecified. That's the largest categorization of falls. But then the second largest categorization is falling from the same level on the top chart, and then falling on or from steps or stairs at 409, and then going down. These are the top categorizations for types of falls for that demographic. Now, when you look in terms of 2020, the 6th highest fall-related ICD codes for the ages 65 and over, both sexes and all races. Once again, unspecified falls where the details really weren't available when the ER staff or whoever collected them. It's 16,852. Then other falls from the same level were the second highest ones, stairs, and then you see new entrances like the bed, slipping and tripping, and then falling from a wheelchair, affecting that demographic. Now, Sydney, I'd like you to put up the next poll question, please. And ladies and gentlemen, I'd like you to think about the last place you fell in the last 12 months.
Okay, the poll is up. I apologize if there's some background noise. We have some people in the background. The poll question is, where is the last place where you have fallen in the past 12 months? The bathroom, somewhere in the house, not the bathroom, outside the home, or you have not fallen in the past 12 months? So we'll give everyone just a little bit more time. And again, if you can't find the poll, it should either be in your chat box or hopefully it popped up on your screen. If not, you can type in your responses in the chat box. Again, your options are the bathroom, somewhere in the house, not the bathroom, outside the home, and you have not fallen in the past 12 months.
Still ain't figured out how to do it. It popped up and told me to do that, and I did it, and it didn't do anything. So I have no idea.
Okay, well, that's fine. I will tell you the last place I fell in the last 12 months. I actually fell outside. I was placing my dog into the car in the back seat, and I stepped and I caught my shoe on the top of the curb, and so I kind of fell backwards, but luckily I was able to pop back up. I didn't hit my head or anything like that, so I didn't sustain any kind of injury, but I realized I was lucky.
So are the results of our poll, we had 7% of the audience say the bathroom, 10% somewhere else inside the home, 41% outside of the home, and 41% have not fallen. And we also had 3 responses in the chat box, or 4 responses in the chat box that individuals have not fallen.
Okay, great. Thank you very much. I appreciate you providing an answer for this. Now, we're going to move on to look more into types of falls. Debbie, take it away.
Thank you, Karen, and thank you for that information. All of that information is just quite eye-opening. So let's talk a little bit about those types of falls, because there is a science to falls, and the reason that we look at this is a lot of times to help guide our injury prevention activities. How can we focus our efforts to make awareness of this problem, seem like there's a science to it, and there truly is. So when we think about falls, about 43% of falls are what we call ground level falls. Both feet were on the ground, and it was a simple fall that resulted in someone striking the ground. About 14% of falls are due to steps and stairs. 11% of falls are due to curbs and sidewalks. Even a small elevation in a sidewalk can cause a fall. About 9% of falls are caused by furniture tipping over or being unsteady. 4% of falls happen in the bathroom, trying to get out of a slippery tub, trying to raise oneself from the shower or toilet. And about 26% of falls involve the other category, which can include falls related to pets. Next slide. Again, more types of falls. We can fall from vehicles, from furniture, and pet-related falls. Falls from vehicles can occur when attempting to enter or exit a car. Getting into or out of a vehicle can certainly be tricky. Oftentimes, there isn't anything to hold on to, and the height of the seat in the car might be too high or too low, and car doors are often very heavy. Surfaces around the vehicle may be uneven or slippery, and if you attempt to grab a steering wheel to assist and it's not locked, it can suddenly turn and throw you off balance. Couches and chairs can be at very low levels, making it difficult to maintain your balance when attempting to sit down. Or if you're attempting to rise from a couch or a chair, that requires quite a bit of leg strength and balance, and oftentimes lower body weakness and an inability to keep your balance can result from a fall forward. As much joy as our pets bring us, joy and companionship, unfortunately, sometimes they can contribute to a fall. Tripping over a pet who is underfoot happens frequently. And pets who are not well behaved on a leash may pull hard, causing the owner to fall. Or a pet who gets excited and jumps on a person who isn't expecting it could cause a fall. Next slide. About 60% of falls happen inside the home. Another 30% of the falls occur outside of the home in a community setting, such as a shopping center or just walking in the street. And an astounding 10% of falls occur in healthcare centers, such as a hospital, a doctor's office, or a nursing or rehab facility. Next slide, please. Now let's look at some of the common areas that we fall and things in those particular areas that can contribute to a fall. About 14% of falls are in living rooms. Often, living rooms can have clutter, area rugs, power cords, unstable furniture, and blocked pathways. Bedrooms can often become cluttered as well, or something as simple as falling out of bed, trying to dress in the morning or in the evening, and you lose your balance trying to put your pants on or trying to put your shirt on. Sometimes lighting in a bedroom isn't that great and can cause you to trip and fall. About 17% of falls occur in kitchens. Unfortunately, even a small amount of water spilled on the floor can pose a huge hazard. Reaching for objects that are in high places can cause you to lose your balance. And then there's the dreaded step stools. They can certainly cause a fall. Our bathrooms. Wet floors are certainly a hazard. And lowering or standing up from the toilet can be difficult. And lastly, stairs, uneven steps, loose carpeting, poor lighting, or unstable handrails can all contribute to a fall. Next slide. Now, also talking about falls, let's talk about some of the chronic conditions and environmental hazards that can contribute to falls, because a lot of these are modifiable risks. Some are not, but some are modifiable. But I think just being aware of the fact that these things contribute to falls helps change our mindset and create muscle memory in our brains that tells us when to be more cautious. About 80% of older adults have at least one chronic condition, such as diabetes, lung disease, or arthritis. Often, these conditions can increase the risk of falling because they result in loss of function, inactivity, depression, pain, or multiple medications. Health conditions such as Parkinson's disease and Alzheimer's disease affect balance, physical strength, joint integrity, and cognitive function. Poor physical health increases a person's initial risk of falling and minimizes their ability to respond to hazards and recover from falls. Peripheral neuropathy or nerve damage can cause numbness in your feet that make it very difficult for anyone to sense their environment or hazards and get around safely. Dim lights, cords on the floor, clutter, loose carpeting, and throw rugs. Any of those can cause a hazard and a risk of fall. Low chairs that are difficult to rise from and require a lot of lower body strength can be problematic. Carrying too many objects and objects in both hands can affect your balance and can obstruct your view that could result in a fall. This is a particular problem on stairs. Walking too fast or running to answer a phone or go to the bathroom or answer the door. Anything that causes you to not be as careful as you should be can contribute to a fall. And sometimes something as simple as not watching where you're going can lead to a fall. A small rock in the road, a small change in elevation can lead to a fall. Next slide, please. And then we have impaired vision, lots of medications, just an overall decline in physical fitness, and situational factors. Age-related eye diseases make it difficult, if not impossible, to detect fall hazards such as steps, wet surfaces, and thresholds. Cataracts and glaucoma alter a depth perception, decrease visual acuity, and your peripheral vision. All of these things, as well as making susceptibility to glare, can alter your ability to see your environment properly. Most often, medications all have side effects. Some of these side effects can upset your balance and make you fall. Medicines for depression, sleep problems, and high blood pressure often cause falls. Some medicines for diabetes and heart conditions can make you unsteady on your feet. Many drugs can reduce your mental alertness and affect your balance and gait and cause drops in your blood pressure when you're standing. All medications have certain side effects. Being aware of what these side effects are can help mitigate or limit some of the responses. If you are taking more than 4 or more medicines or have changed your medicines in the last several weeks, that can certainly contribute to a fall. Many adults simply become less active as they get older, which exacerbates the physical effects of aging. Failure to engage in even mild activities or exercise on a regular basis results in reduced muscle mass, strength, decreased bone mass, and poor balance and coordination. Not only does overall deconditioning increase a senior's risk of falling, but it also increases the likelihood that they will incur a serious injury and experience a much longer recovery time. Certain activities or decisions increase the risk of fall-related injuries, such as walking and talking, being distracted by multitasking, and failing to notice environmental hazards. Next slide, please.
Ooh, Debbie, I think we had a technical issue where someone stole the capabilities again. So Karon, can you reshare the screen? I'm sorry.
Okay. Oh, you can't see it? Okay. I'm going to just end the show.
Stand by, folks. We'll be right back. We
Yay,
are
technology.
regaining control of the screen. We're still here. We're just going to recontrol the screen and get back on our slides.
Okay. Can you see it?
We can.
Yes.
Thank you,
Sorry
Karon.
about that.
Okay.
And as you can see by this slide, there are a lot of just conditions in general that can contribute to a fall. Even vitamin D is probably one of our most important vitamins. You should talk to your physician or healthcare provider about vitamin D supplements. Vitamin D is necessary for strong bones and muscles. The body needs vitamin D to effectively absorb calcium, which is great for our bone health. Foot pain. Any kind of foot pain or abnormalities or deficits in sensation can contribute to a fall. Calluses, bunions, overgrown or thick toenails can contribute to a fall. A podiatrist can help identify and treat a lot of foot problems. They can even prescribe corrective orthotics to be worn. Falls are often caused by dizziness, lightheadedness, and fainting. But there may be underlying problems such as inner ear issues, dehydration, or even a simple urinary tract infection. Postural hypertension is simply just a fancy term for saying a person's blood pressure didn't have enough time to correct itself before standing, which leaves a person dizzy and unsteady on their feet. To avoid this feeling, make sure to drink plenty of water during the day and take your time when you're trying to stand, especially after sitting. Next slide, please. There's several different types of conditions that can be likely to make you fall. As we age, dizziness can be a contributor to falls. Vertigo can be described as a sensation of whirling and loss of balance. Disequilibrium refers to the loss of balance or spatial disorientation. Lightheadedness or feeling woozy is commonly caused by dehydration, side effects of drugs, blood pressure drops, low blood sugar. And finally, what we call pre-syncope is what you feel when you're about to pass out but don't actually faint. Those symptoms can include trouble hearing, palpitations, or suddenly feeling weak and sweaty. Next slide, please. About 40% of nursing home admissions are due to falls. Falls, and particularly falling repeatedly, greatly increases your risk of hospitalization and death. And if you have fallen once, your chances of falling again are doubled. About half of people who fall cannot get up without help. Remaining on the floor for greater than 2 hours increases your risk of dehydration, pressure ulcers, hypothermia, and pneumonia. Function and quality of life can deteriorate drastically after a fall, and about 50% of older people who were ambulatory before fracturing a hip do not recover their previous level of mobility. After falling, old people may fear falling again, so mobility is sometimes reduced because confidence is lost. Some people even avoid certain activities such as shopping or cleaning because of this fear. decreased activity only contributes to joint stiffness, weakness, and further reduction of mobility. And Karon, I will pass it back to you.
Okay, thank you so much, Debbie. Both Debbie and I have shown you aspects of falls in terms of their impact and also their costs. Falls are definitely a growing public health emergency, but by showing up today to get educated, you're getting ready to empower yourself. It's important to know when you're engaging in activities and when you're talking with your friends about falling, about this growing health emergency. 10,000 Americans turn 65 every day. 1 in 4 fall every day. 20 to 30% of those who fall are seriously injured, as Debbie just pointed out, be it head injuries, broken bones that may never heal properly, or so on. And then 8,500,000 people will be hospitalized for some of these fall-related injuries. When you look at the cost, this is a growing crisis for our healthcare system. $50 billion, according to the CDC, are spent every year in terms of falls. And this was based on actually 2015 data from the CDC. The cost is much higher now, but unfortunately we couldn't find that data. But when you look at that $50 billion price tag, $9 billion comes from Medicaid, $12 billion comes from private pay insurance or out-of-pocket costs, and then $29 billion comes from Medicare. Now, looking more at the cost of falls, they're broken down by direct costs and indirect costs. When you talk about direct costs, those are things like expenses and charges for insurance companies, for hospitalization, staying in skilled nursing facilities after discharge from the hospital, where you receive rehab, the use of medical equipment, and so on. Indirect costs are things like long-term disability that you may be subject to, decreased productivity, and also decreased quality of life. As you can see, when you examine the 2020 data for falls, unintended falls, emergency room visits, there were 2.16 million, medical costs of 18.78 billion, with the average being $8,701. In terms of hospitalizations, 1.1 million for a cost of 58.63 billion, with an average cost for hospitalizations of 52,866. When you look at these combined totals, these are some interesting figures. For emergency room visits, for the 2.16 million folks, that totaled $312.59 billion. And hospitalizations for the 1.1 million individuals, $292.20 billion. But hospitalizations and ER visits aren't the only thing when you're talking about falls. Fatalities due to falls, those unintended deaths. This affected 38,413 individuals at a cost in terms of medical costs of $1.46 billion, with the average being 37,908. But when you calculate in the statistical life value for these fatalities, the combined cost is $135.24 billion, and then the average being $3.52 million. Because September is Suicide Prevention Month, it's important to kind of look at another statistic regarding fatalities and falls. There is actually a suicide component. For adults 60 and older, 246 deaths due to falls were tied with suicides. The medical costs for these are $1.48 million, with a combined total cost of $1.72 billion. Moving on, when you talk about Tennessee-specific falls, Governor Lee noted in his 2020 state proclamation that the financial burden for older adults as a result of falls was $885 million in this state. It has been noted by the Center for Disease Control and Prevention's 2019 statistics that Tennessee is among the top 5 states with the highest per capita cost for unintended injury deaths, and falls fall within the categorization of unintended injuries. And then when you look at a recent Genworth study on the cost of care, once you sustain a fall, the approximate monthly median cost of care in Tennessee, based on 44 hours of care a week, if you have in-home care, meaning you've been treated in the hospital, possibly in a skilled nursing facility, and discharged home, but you still require some type of assistance, the monthly cost is $4,576. If you remain when you're in an assisted living facility, you're paying $4,105. And then if you were regrettably have to remain in a nursing home, that's $7,665 a month as the estimated cost. Now, Debbie will take us through a case study involving a fictionalized patient.
Thank you, Karon. And as Karon mentioned, I'll just reiterate, this is not a real case study, but as I actively participate in geriatric trauma rounds here in my position at the hospital, I can tell you that this is a typical course, hospitalization course. So Mrs. Case is a 70-year-old female whose husband died 5 years ago. She currently lives alone and functions daily independently. She has 2 grown daughters who live within 10 miles of her home. She has a history of a heart attack, diabetes, hypertension, and glaucoma. Her only previous surgery was as a result of a fall while carrying groceries in the home 2 years ago that did result in a hip fracture. Mrs. Case underwent surgical fixation of her hip and spent 2 weeks at a rehabilitation facility to regain strength and balance. Today, she's brought to the trauma center by an ambulance after repeated calls by her daughter to check on her, but she didn't answer the phone. The daughter arrived at Mrs. Case's home and found her very confused, lying on the bedroom floor, saturated in urine, with an obvious huge bruise to her forehead and unable to move her right hip and leg, and had a deformity. Mrs. Case arrives at the trauma center via ambulance, fully immobilized on a long spine board, with a C-collar in place, and oxygen being administered via nasal cannula. Upon the patient's arrival, her clothing is cut off, and a full primary and secondary assessment is performed by the trauma team. The findings are as follows. She is lethargic and only oriented to name. Her airway is patent. Her breathing is regular and unlabored. She has very dry mucous membranes with signs of dehydration. She has a weak pulse in her right foot and an obvious fracture to her right femur. She is connected to the heart monitor. Additional IV access is obtained, and lab work is drawn. An EKG is done, CT scan of her head, chest, abdomen, and pelvis, as well as plain films of her right hip, pelvis, and right femur. Mrs. Case's daughter arrives and provides her mother's medical history. She states that the current mental status being shown by Mrs. Case is not normal for her. The daughter states that she tried calling her mother as usual for several hours but received no answer. She went to check on her and found her on the floor. Her nightstand was knocked over and dried blood to her forehead. The primary and secondary surveys reveal the following diagnosis. Mrs. Case has a subarachnoid hemorrhage with a skull fracture, dehydration, acute kidney injury related to the dehydration, as well as a right hip and right femur fracture. Mrs. Case will be admitted to the ICU for close monitoring with consults made to surgical critical care, neurosurgery, and orthopedics. Orthopedics plans for an open reduction internal fixation of her right hip and her right femur, and her right hip will be managed non-operatively. Neurosurgery will closely monitor her neurological status and plan on repeat CTs for any worsening of her mentation. Mrs. Case is sent to surgery on hospital day 2 for repair of her right femur, and she remains in the ICU post-op for monitoring. Her mental status continues to be confused per her daughter. Hemodynamic monitoring is stable, and Mrs. Case is transferred from the ICU to the acute care floor on hospital day number 3. Hospital day number 4. Mrs. Case will begin working with physical therapy today. She reports a lot of pain in her hip and femur with only minimal relief from pain medications. Mrs. Case has found voiding or urinating to be very difficult since surgery and has required a urinary catheter to assist with emptying her bladder. Hospital day 5. Mrs. Case's daughter comes to visit her mother and reports to the nursing staff that her mother is much more confused today and not agreeable to work with physical therapy. The nursing staff report to the daughter that Mrs. Case suffered from delirium last night, probably related to lack of sleep and pain control issues. Her pain medicines are adjusted and additional nursing interventions aimed at reducing the effects of delirium are implemented. Hospital day number 7. Mrs. Case's daughter reports that her mother's mental status has improved, but she feels her mother is depressed and worried about being able to take care of herself at discharge. The daughter reports that care 24/7 would not be available at this time, and that maybe some rehab at a skilled nursing facility could help get her mother back to her pre-injury level of independence. Hospital day number 8. Case management reports that all skilled nursing facilities are currently at capacity and would not have an available bed for 3 more days. Hospital days 9, 10, and 11. Mrs. Case continues to work with physical therapy, but feels she has gotten very weak while being in the hospital. She reports a slight headache and intermittent confusion. Hospital day number 12. Mrs. Case is finally discharged to a skilled nursing facility. After spending 12 days in the hospital, Mrs. Case is discharged, but sadly, her deconditioning continues and ultimately is decided that she should no longer live independently. Mrs. Case at that point transitions to a nursing home where she will receive assistance with meals, bathing, and medication. Next slide, please. Now, there is some good news in all this. Please, falling is not a normal part of aging, and there are things you can do to prevent it from happening. Talk to your healthcare providers, talk to your family, ask for an assessment of your risk for falling, and be honest when you share your history of recent falls. And I'll turn it back over to Karon for some more encouraging and empowering news.
Thank you very much, Debbie. As Debbie said, falling is not a normal part of aging. That's a myth that we want to bust. And there are several partners who can help you with them. First off, your doctor. Hopefully your physician is aware of this wonderful program put out by the Center for Disease Control and Prevention, and that's the STEADY program, Stopping Elderly Accidents, Deaths, and Injuries. This is a wonderful program where your physician partners with other healthcare professionals who can help you with in terms of falling. Physical therapists, occupational therapists, pharmacists, and so on can all come together and help you come up with a plan by doing several core elements. One is screening for your fall risk. There are certain assessments that physical therapists can give you to determine your gait and rate of speed, and then start as a starting point, and then certainly work with you to improve those things. You can get access. You can, access things that can help you decrease your modifiable fall risks. Things like home modifications, just making sure, surveying your outside environment, making sure that it's safe, there's no cracked sidewalks or so on in your normal route of walking. And then intervening, once again, continuing to reduce those risks that when you're out in the community, and then using things that exist in your community, such as exercise programs or other things, educational series, and so on. Now, in terms of strength and balance programs, things that you will find in your communities, I want to highlight the SAIL program, which stands to Stay Active and Independent for Life. And I know we have several SAIL instructors on the line with us. This is a wonderful program found in several counties, primarily through your senior centers or your area councils on aging. Consult them to find out where the SAIL location is near you. Another excellent program is A Matter of Balance. This is an excellent program found primarily, I believe, in the eastern part of the state, but it also incorporates several elements of strengthening and balancing, both for your upper and lower extremities. And then Tai Chi, this ancient martial arts, is an excellent way to increase your balance. Next slide. I'll turn it over to Debbie now to talk about the 6 crucial steps for preventing falls.
We're going to wrap things up with a summary, and I think that these 6 steps and these 6 things are just ones that every one of us can take a look at to help reduce the risk of our falls. Staying active, even 15 to 30 minutes of exercise a day helps keep your body flexible, stable, and stronger. Reviewing your medications with your doctor or pharmacist, and especially if you take more than 4 medications. Many of these medications have side effects as dizziness or drowsiness. Keeping your home safe. As we talked about today, every room in the home has potential for falls. Removing tripping hazards, getting rid of throw rugs, wiping up spills, and removing clutter. Make sure you talk to your healthcare provider about your concerns. They can assess your risks and help modify and mitigate many of these things. Getting your vision and hearing checked annually is more important than you can possibly imagine. Having your eyes examined and making sure your prescription is current. And finally, talk to your family members. Insist their support and taking those simple steps to stay safe. Falls are really not just a seniors issue. All right, Karon, I'll throw it back to you, and I guess we'll finish up and look for questions.
All right, thank you so much, Debbie. Now, ladies and gentlemen, we'd love to answer any questions that you may have.
Yeah, we had a couple questions come into the chat box. So back at the beginning of your presentation, when you were going over all of the great data, you referred to older adults a lot. Can you tell us what the age range of that's considered older adult?
In terms of the data points, most of the time when you're talking about older adults, 65 and older is the time frame that there is typically used by the CDC in terms of fall-related data. However, data does exist for each one of the age groups, starting certainly with infants and then infants, toddlers, and then working its way up. But for the portion of this briefing, primarily tried to limit it to 60 and above. In some cases, I think I went down to 55 and above.
And I could just add a little bit to that. As the Level 1 Trauma Center and a geriatric trauma program here, anyone 55 and older, because we go by what the American College of Surgeons describes as geriatric. So 55 and older, if they come in with significant injury, mechanism of injury, comorbidities, ages 55 and older are evaluated in a multidisciplinary setting by the geriatric trauma team. And a lot of the data that we collect internally is for 55 and older.
Wonderful, thank you. Another question came in, where do most falls happen?
Most falls happen in the home. And then I think, Debbie, you had some more data about specifically where in the home.
Mm-hmm. Yep, most falls do occur in the home. About 60% of all falls occur in a person's home or in a home. If they're even over visiting a friend's home, it's still considered a home. 30% of falls occur either in the community, such as a shopping center, the mall, and then 10% of falls, believe it or not, and that's a large number, occur at healthcare facilities such as hospitals, doctors' offices, clinics, nursing facilities, or rehabilitation centers.
And when you're talking about falls in the home, you have to be particularly aware of the bathroom. The bathroom can be certainly a changing environment. Initially, maybe before your shower, it's fine. Coming out of your shower and showering and bathing are strenuous activities. They certainly can be strenuous activities because you're constantly working your upper body, and then in doing activities, you're twisting, you're bending, you're things like that. You have warm water that's coming, so there's an elevated temperature, and then stepping out of the shower, you probably have a throw rug. So now you're talking about a humid, wet environment. So you have to be particularly careful when you're in the bathroom, and then doing things like trying to dry off, and then if you're trying to stand and dress, as Debbie pointed out in her example, those can be activities that you have to be careful of. And then, of course, your things like your steps. If you have a two-level house, navigating your steps, whether they're carpeted or uncarpeted. Are there throw rugs, which occupational therapists, when we do home assessments, we always look for the throw rugs because they're tripping hazards.
We also had some comments come in about the costs that you talked about, Karon, and we have a lot of personal experiences, unfortunately, that back up the data that you mentioned. We had a question come in, can we get a copy of the slides? Yes, Debbie and Karon have been graceful enough to send me their information, and I will send a follow-up email with all of that information for everyone. A couple more questions came in. In the data summary, did it break down the stats by gender, female, male?
Yes, they did. However, for the benefit of this presentation, I didn't go into it. But in terms of who falls most, if you were interested in that, actually females do fall more than males. Just that's what the data certainly indicates. But everyone, male, female, non-binary, everyone needs to be conscious of the risk of falls.
Let's see. Oh, sorry, was that L? In the slide with the cost to Medicare, private pay, and Medicaid, does that include the VA system for costs?
And that was just kind of a general roll up, and that was actually, like I said, 2015 data. So the next slide that had the more 2020 was more relevant. What I found is the CDC did not break it out by specific type of source, VA versus private pay, private insurance, or another facility like St. Thomas or Centennial. So I think the VA probably does have its own data. However, I did not pull that for this presentation.
Is there a recommended checklist to survey our home for risks?
Yes, there was. Yes. Oh yeah, okay. So I'll kind of indicate one, and now I'll let Debbie do one. But the National Council on Aging has some wonderful checklists that are available, as does AARP. These checklists are available through their websites. Debbie?
Oh, I was just going to reiterate that exact same thing. There's several resources out there that are very, very easy to use, and I can even share electronically with Sydney if she wants to distribute as well with our PowerPoint slides.
Yes, Debbie, if you wouldn't mind sending that over to me,
sure.
I'll include it in the follow-up that I plan to send to everyone this afternoon.
Great.
We had one more question come in the chat box, and then we have someone who's raised their hand. I know we have only about a minute left, so I want to respect everyone's time and thank you all for being with us today. If you have to hop off, we completely understand, but if everyone else could kind of hold on for another minute to wrap up these last couple questions, that would be great as well. But thank you to Debbie and Karon for this amazing presentation. The next question that came in is walking barefoot in the home dangerous?
I think I'll throw that one to you, Karon.
Well, I think that's probably a personal choice. There may be things that's a personal choice. You probably would want to make sure that your home. I cannot offer you medical advice, like I said, because that's a personal choice. But when you're walking barefoot, you may be susceptible to stepping on things that are a surprise for you. I know we have a dog here, so and sometimes our dog eats with his mouth open, so you might be stepping on a piece of kibble that you didn't quite intend to step on. So there may be other things in your environment. I would just encourage you to, if you are wearing footwear and some kind of slipper or something like that, make sure it has tread in it, tread that grips fairly well. But whether or not you want to walk barefoot in your house is a personal choice.
We do see a lot of falls related to wearing socks in the home.
Interesting.
Mm-hmm.
Is that because it's slippery on the bottom,
Mhm.
maybe? Not as much
Mhm.
traction? That makes sense. And then Stacy Banks, you have your hand up. You are welcome to unmute yourself and ask your question.
All right, it's a two-part question. Thank you very much. First of all, on that slide that showed that the falls would increase by 2030 to 7 per hour, what are they attributing that such a drastic increase to? I mean, you guys had mentioned in one of the other slides all the things that were impacting, causing falls. What are they attributing this drastic increase in 2030? That's the first part.
One being the aging population, is the rapid aging of the population. We are becoming a graying population, and so as the population increases, so does the risk of falls. And I think that is really kind of taking a dismal look if people aren't doing the things that we talked about if people don't do the things we kind of that are recommended for decreasing fall risk, such as getting their medication assessed, so that making sure they don't have something that encourages sleepiness or drowsiness. Can they reduce the dose or stop taking it, making sure there's no kind of polypharmacy interactions. And then if people aren't engaging in strengthening and balancing or just some kind of mild regular exercising program, if we continue to see a rise in things like the chronic conditions that may plague individuals, or obesity or things like that. So
okay, thank you. So that answered the first part, and you touched on the second part. In the slide that lists the main contributors, where does the medication fit in there as far as like the top 3 or top 5 as contributors to falls? You mentioned comorbidities,
Yes.
lack of exercise, and things of that nature. Where does medication contribute? Where would they fall into that, say, top 5 for contributors to falls?
Personally, I think it would be weighted just as heavily as the others. It's really amazing the amount of medications that we're on and that don't work well together or that are inappropriate for our senior population. And so if medications does weigh very heavily. Huge correlation between even a blood pressure medication that's certainly meant to control blood pressure, but it causes what we call orthostatic hypotension or postural hypotension. Those falls can happen in an instant, and a medication that's meant to help you keep you healthy could contribute to a fall.
Okay, thank you. I was wondering, and you partially answered that, but I was just wondering if there was any data that support, that showed a specific percentage or number that the medication contributed.
I do want to kind of direct you to a resource that might be available. Actually, if you are able to, and I think you should be through the YouTube channel, go back to the 2021 presentation on the first day. There was an excellent portion of the introductory presentation on falls last year. We had a registered pharmacist who spoke as part of the lecture series, and she actually had a listing of falls and some of their a listing of medications and some of their the contributing factors toward falls that you need to be aware of. So that's and certainly, as Debbie indicated, I'm sure it's certainly right there in the top 5. I don't have the actual figures right here in front of me, but if you refer back to that presentation last year, which should be on the YouTube channel, there was, like I said, there was an excellent laydown, really digging into the pharmaceutical aspect.
Okay, thank you very much, ladies. Enjoy the presentation.
Thank you,
sir.
Yes, and thank you, Stacy, for your patience and hanging with us a little bit more over time. But I think that was all of the questions that came through. So again, we want to thank Karon and Debbie for this amazing presentation. A lot of great feedback in the chat box. We will also be sending an evaluation out to everyone via email early next week to kind of review the entire series. So thank you all so much again. And I hope you all have a great rest of the week and can join us for more of our session series. I'm going to go ahead and stop the recording. And then if maybe we have a couple follow-up questions for individuals who may not wanted to ask their question while we're being recorded, we can see if we can field any of those. But thank you all so much again and have a great rest of your day. Alrighty, I believe our recording is still going somehow. Stop. There we go.